Rama. Hello, everyone.
Hi, Dr. Ahmad.
Hello.
Hi, how
Good
are
to
you?
see you. MashaAllah.
MashaAllah. Good to
Always
see
good,
you
good
too.
shape, MashaAllah. Very nice.
Alhamdulillah.
Alhamdulillah. Very nice, very nice. So we'll wait for 3 minutes.
Yes.
There's a video, introduction video from the team, Pearl team, who are doing the logistics for this webinar.
Right.
Rama, you're here? Someone from Pearl here? Connecting, okay. So yeah, hello?
Hello, good afternoon.
Good afternoon, yes. Rama?
Yes, I'm with you.
Very good, so perfect. So I will do a quick introduction for Dr. Shahzad. He will be first because it's late there in Pakistan. You're in Pakistan, right? In Lahore today?
Yes, I'm in Lahore. Yes, yes.
You're not traveling.
No, I'm not traveling. Yeah.
That's great. So we'll have the great pleasure to have your lecture. I'm pleased. I advertise a lot about what you're doing there, and inshallah we'll have a great collaboration together, inshallah.
Inshallah, looking forward to it,
Yes.
and helping our brothers and sisters, inshallah.
Yes, definitely.
Yes.
So Rama, can you hear me?
Yes, doctor.
Yes, you just let me know when everything is ready to kick off. So we still have 2 minutes, I think. You have the control. We have already 422. Oh my God, mashallah.
Yes. And we have also on YouTube. We have around 100 also.
On YouTube, okay. I think we were limited to 500 on Zoom.
On
and
Zoom.
the other, yeah, true.
Yes,
And what
that's
about Facebook? Are we on Facebook as well?
No, on YouTube.
Right.
Yeah, why not doing live Facebook?
Yes, we can do it.
Yes,
Yeah,
please
if you can do it. Yeah,
Sure,
you
we
can do that.
it.
Yes, please. Because I think we reach the limit of 500. So it's good to have it in Facebook Live. Especially, I guess many of our friends from the States cannot join, so they can see it later.
Yes, I mean.
Very good. So Rama, you just tell us when you are ready, we can start. Rama is the lady who organized all the logistics from Pearl Company. So Pearl Company is organizing company for conferences, for webinars. They're expert in medical conferences mainly. They have good network. I guess that's why we have like 3,500 registrants. They have a big number and big network for advertising, and they have good reputation here in UAE.
So what about the remaining who got registered, but we only have the capacity of 500? What will they do?
They will be transferred to YouTube and Facebook Live.
Right.
Yeah. Okay, it's 7 p.m. Are we live, Rama?
Yes, we are live.
Okay, perfect.
You can start wherever you want.
Okay, very good.
Thank you so much.
Yes, thank you very much. So good evening, everyone. I'm Dr. Salti. I'm a consultant anesthesiologist and pain physician in Cleveland Clinic, Abu Dhabi. I have the great pleasure tonight to kick off this these webinar series named Pain and Regenerative Medicine. It's a great honor for me to gather all our colleagues and friends from all over the globe who are joining us tonight for the first series. I organize workshops and procedures for interventions on cadavers through the platform Gulf Pain School. And my very interesting conference and course that I've done during the COVID in 2020 was done in collaboration with Dubai Expo, which was a huge event in Dubai. So I did what we called the Pain Expo, where we invited lots of friends from different parts of the world, including some great names from pain medicine, like Professor Sudhir Diwan and Professor Shahzad Anwar from Pakistan. And during this big event, we were discussing about the future of pain medicine and what we can do for our future generation and how we can help our patients with our knowledge and expertise. And the word that I remember is that, as Professor Sudhir Diwan said, regenerative medicine will be the future of pain medicine. And not only the pain medicine, even the medicine. So this was clicking in my mind, and I was thinking that we need to collaborate with different actors in this field to have and to spread the knowledge about pain and regenerative medicine. That's why we named these webinars and series Pain and Regenerative Medicine. And also I have the pleasure recently to visit my friend Shahzad, who invited me to Lahore, where I also met with a great person from Pakistan who really spread the knowledge about pain medicine in the whole region in Asia. Brigadier Salim, who was one who inspired all these great people in Pakistan and the region to learn about pain and to really spread the knowledge and treat these patients and have this great opportunity to help our community, our pain community. So with this collaboration with Professor Sudhir Diwan, Brigadier Salim, Dr. Shahzad, myself, and many other friends from the region, we decided to go further and start this great endeavor for education regarding pain and regenerative medicine. So without further ado, I'm not going to take much from your time. I know it's time is different from different parts of the world, from east to west. So I have the pleasure to start presenting my good friend, Dr. Shahzad Anwar, who's interventional spine and pain medicine physician and regenerative medicine with over 20 years of experience. He started his medical school in Allama Iqbal Medical College in Lahore, and then did his fellowship in different parts of the world, including Beijing, Cardiff, and he is fellowship laureate of interventional pain medicine from the Pain School International in Hungary, fellowship in interventional pain practice FIP in USA, and fellowship in endoscopic spine surgery from Turkey. He's diplomat from all these great platforms for pain management, and he's one of those in Pakistan who was awarded a fellowship of American Board of Regenerative Medicine. Dr. Shahzad is the founding president of Society of Interventional Pain Medicine in Pakistan. He runs his own hospital, Ifat Anwar Medical Center Complex, 50+ bedded multi-specialty healthcare facility where plenty of good things and good practice are done. And one of them will be, many of them will be presented tonight during his talk. He's a faculty member of the following universities and institutions: Rifa International University, Islamabad, Pakistan; World Institute of Pain, Pain School International, Hungary, and the World Academy of Endoscopic Spine Surgery in Turkey. It's a great pleasure for me to hand over to Dr. Shahzad, who is going to start. In the agenda, I was planning to start, but honor to our guests from outside UAE. So in Pakistan, Dr. Shahzad, the floor is yours.
Thank you so very much, Dr. Amar. It's really an honor, and I feel humbled to be part of this great endeavor you have started, and look forward that we will work together with all those consultants working in regenerative medicine and interventional pain medicine, and could help millions of suffering patients who are otherwise thought to be untreatable. Right. So today I will be discussing about the regenerative medicine, the basics, and the evolving applications. I think everybody can see my screen.
Yes, we can see your screen. Yes.
Yes, right?
Yes, me too.
So, Bismillah ar-Rahman ar-Rahim, in the name of Allah, the most benevolent and the most merciful. Right? So basics and the evolving applications of regenerative medicine. My disclosures already have been introduced by Dr. Amar. No financial disclosures for this talk, though I speak on regenerative medicine and interventional pain for different organizations, right? So coming to regenerative medicine, if we broadly define regenerative medicine, it could be said that regenerative medicine is an interdisciplinary field that involves the use of growth factors, cells, tissues, or organs to restore or replace damaged or diseased cells, tissues, or organs, right? So its ultimate goal is to help body heal itself from inner side, right? By triggering the regeneration of damaged or lost cells and tissues, right? So the basic purpose is to stimulate or regenerate the damaged or diseased tissue or restore the function of different organs and tissues. There are two basic types of regenerative medicine. One is the cell-based therapies. We as physicians are concerned with that. It includes PRP, platelet-rich plasma, stem cell therapy, especially we will be talking about the autologous stem cell therapy, gene therapy, precision medicine, all those things in cell-based therapies. Regarding the other part, that is tissue engineering, biomaterials, and 3D printing, that is more related with the basic scientists. So our focus today will be cell-based therapies. So before coming to that, if we define aging, the aging is actually what happens when we cross 4th or 5th decade of life. What happens, the body, the breakdown mechanism or the breakdown equilibrium shifts in the favor of breakdown rather than repair work. That is what we normally see with degenerative arthritis, other degenerative conditions. So this is degeneration or disequilibrium of aging is the major thing which we can address with the regenerative medicine. So the basic principle of regenerative medicine is to shift the balance from breakdown to the repair side. So that helps. That is done by the different modalities. We have like prolotherapy is one good option, but I will not be discussing that because we are concerned with cellular therapy. So PRP is autologous stem cell therapy, and then something like exosomes, which are acellular but are derived from the human tissue. And so we'll be discussing all those things. So why do we use regenerative medicine, right? The major purpose for choosing the regenerative medicine cascade or any of the things is it can reduce pain by reducing the inflammation or other underlying causes. It can heal the effects of it can heal the affected degenerative and inflamed tissues. It stops or slows down the process of degeneration and provide the regeneration of tissues and organs. So with this, we not only treat the symptoms, we can also address the root cause as well and change the course of the disease. Right. So the treatment objectives include to improve the ratio between cell loss and the cell production, or the apoptosis or the cell regeneration. Then by using different modalities of like PRP or platelet poor plasma or different things, we can improve the hostile microenvironment. So this hostile microenvironment means increased oxygen tension, lactic acidosis. All these things come up in chronic inflammation. And chronic inflammation is one major cause for accelerated aging or degenerative process. So this definitely affects those things. And that is one other contributory factor with which we slows down the aging process, chronic inflammation, and then the regenerative cascade. It provides an anabolic state to inhibit cytokines that degrade prostaglandins, right? Then stimulate proteoglycan and glycoprotein glycan GPG. So again, these two molecules help in regeneration and in cell replication and intercellular communication. I will not go into all that physiology and details, but these factors, they also provide important growth factors to promote extracellular matrix. So one thing we should be very clear about, that it's not only the cellular or the tissue regeneration, we also the importance of extracellular matrix, that is proteins and the other substances, they are also very important. So when we'll be discussing the composition of PRP and stem cells, you will know it's not only affects the cellular regeneration, it also intercellular communication and extracellular matrix. So that is very important for long-term beneficial effects of regenerative medicine. So ultimately what it does, it provides repair and regeneration of diseased cells. So you can see the picture, the purpose is to create the balance between cell production, cell regeneration, and the cell loss, right? Or to stimulate the function of the diseased cells. So coming to the evidence for regenerative medicine, you can see it's really a hot topic for research for last few years. If we go through PubMed, during the 2021, there were more than 14,000 papers published, and including nearly 250 systematic and reviews and meta-analysis. And if we look at PubMed and we search for regenerative medicine, we'll find more than 94,000 results for regenerative medicine. And similarly, when we search for stem cell therapy, we'll find more than 150,000 results for stem cell therapy. So huge work going on. So now coming to what treatment to choose and why. So now regarding regenerative medicine, we have two options. One is the acellular therapies, the other is the cellular therapies. If we talk of the acellular therapies, they include exosomes and microvesicles, alpha-2 macroglobulin, it could be autologous or it could be recombinant, then high-density collagen, recombinant growth factors, intradiscal fibrin sealant, and there are few others also commercially available, right? Then regarding cellular therapies, the most commonly used one is platelet-rich plasma, then autologous stem cell therapy. At our center and in many other parts of the world, there are three major sources for autologous stem cell therapy. The most common one is bone marrow concentrate, which is considered as minimally invasive in USA, and physician can do it there. Then adipose-derived stromal vascular fraction. This again is a beautiful procedure. I will be explaining. And then finally, the most powerful of all is peripheral blood-derived VSCLs, though it's not very commonly done, but we are doing it for last 6 years now. And most of our adult patients who have good peripheral venous lines, we prefer to do it. And the reason is there is just a needle prick, rest is done by the apheresis machine. Then we can use allogenic stem cells, but again, no FDA approval, still on trial base. Then we can have laboratory expanded cells, both allogenic and autologous. But most commonly now we are doing is the combination of platelet-rich plasma and stem cells. But now at present, we have started 2 studies, one for with our retinal surgeons friends for retinitis pigmentosa and Stargardt disease, and we are using 3 combination of PRP, exosomes, and autologous peripheral blood-derived stem cell. Similarly, we are working with the chronic degenerative disc and osteoarthritis using these 3 in combination together. So now coming to very briefly, what is PRP? We all know what PRP is, right? So it's 55% plasma, center 1% is buffy coat, and the remaining 45%. And the central gray part is where all the white blood cells and platelets, they concentrate. Right? This is very important slide, because most of the people who are doing PRPs, they actually are doing it. I might be wrong, but what I've talked to people in different groups word over, they actually have not real clue where to use which type of PRPs. So actually we have 2 types of PRPs. One is leukocyte-rich PRP. As the name indicates, it has more increased number of leukocytes in addition to platelets. It is more pro-inflammatory, but at the same time, it also is associated with elevated catabolic cytokines, especially interleukin-1 beta, tumor necrosis factor alpha, and metalloproteinosis, which inhibit the anabolic cytokines within the platelets. And right, then if we talk of leukocyte poor PRP, these preparations will not have that high number of platelets, but they are very few leukocytes or white cells. When we are doing any intra-articular procedure, like we are doing intra-articular knee joint injection, we are doing intra-articular shoulder, hip, sacroiliac, anywhere, the recommendation is never use leukocyte-rich PRP, because when we will collect the buffy coat, we'll have RBCs, we'll have more leukocytes, and both of these have a, rather than anabolic, they have catabolic effect. And then instead of, once they will have more flare-up, patient will complain of increased pain, flare up after the procedure. And secondly, the cartilage that will be destroyed, because chondrocytes and all these things, I will be explaining that. So they get destroyed. So for those, we need to use leukocyte poor PRP, right? So the procedure is same. You do the soft spin or the hard spin, single skin. And so different techniques we can use for them. Right? I will be coming to that. So why do we use PRP? Right? It contains so many different growth factors which help both cell replication, intercellular communication, and also it helps in the formation of extracellular matrix and also inhibit the hostile environment. So it facilitates all. It includes insulin-like growth factor 1, which helps mediate growth of skeletal muscles. So all muscle and ligament injuries could be helped. Stromal cell-derived growth factor, SDF1 alpha, it supports adhesions, migration of mesenchymal stem cells. So that is why we use PRP along with the stem cell. They will further improve the function or will strengthen their function. Then bone morphogenic protein, growth differentiation factor, PDGF1, right? The chondrocyte, fibroblast, and all those expansion, it helps this growth differentiation factor. Then PDGF, cell replication, and angiogenesis. We all know that new vascularization and angiogenesis is very important for regeneration. So all these factors help in and stimulate angiogenesis, TGF, beta-1, then VEGF, again, all these factors. Then this is very important, fibroblast growth-like factor. It again mediates the growth of skeletal muscle, cell differentiation. So for ligament and tendon injuries, then epidermal growth factors, ectoderm, and growth of all those things. So these are only few of the important ones I have chosen. The list is much longer and you can go through those. Right. Now we all experience that sometimes we inject a patient and we get excellent results, and sometimes, and you search on Google or PubMed, there are so many negative studies. But when we look at the methodology of those studies, we'll find that neither the proper concentration nor the proper composition was used, right? So the efficacy of PRP depends on the concentration, one, and the composition, right? Optimal concentration for angiogenesis is 1.5 to 3 million platelets per microliter. That is, if we talk of the upper limit, it's around 400,000 normally. So anywhere between 4 to 6 times, right? And we should be concerned about one thing: if it's between 1.5 to 3, that's the optimal. That's quite a big window. But at concentration more than 5 million, there is inhibition, right? It has inhibitory effect, but no point of care which is commercially available system, we don't reach. So we should not be worried about the upper limit. We should be worried about that it should not be less than 1.5 million count, right? So, and there is no effect if the concentration is less than 500. So that will be simply a plasma or platelet poor plasma. But we'll be discussing there are other benefits of that. But from the cellular regeneration perspective, this concentration should be between 1.5 to 3 million. And then if we talk of composition for intra-articular, please inject leukocyte poor PRP, right? And how we prepare that? So like if we talk of different systems, mainly 3 systems available. One is the gravitational, other is the closed loop system, and then autologous concentrated plasma system, right? So the most commonly used is this gravitational system, where we centrifuge and then we get the Buffy code. We have both the PRP, platelet-rich plasma, protein-rich plasma, PPP, cellular components, scaffolding protein, and especially alpha-2 macroglobulin. Alpha-2 macroglobulin is very, very important. We'll have request Dr. Ahmed to have a separate talk on it, inshallah, in near future. That is very important, and also an exosome, right? So if we look at the picture on the left side, if we look at the middle, which is the gray Buffy code, for taking the platelet poor plasma, not platelet poor plasma, for leukocyte poor PRP, what we need to do is just 0.5 centimeter above mark one line with the marker, and then your tip of the needle should be there, and then you can take 1, 2, 3 ml depending upon what you need. That is the leukocyte poor PRP, right? And that is the one which we should inject intra-articular, because it has very less white cells, no RBCs, it has reasonable number of platelets, but most importantly, it has the maximum concentration of alpha-2 macroglobulin. alpha-2 macroglobulin is very, very important in the regeneration and stimulation of the cartilage synthesis, right? So that is how we prepare PRP. Then alpha-2 macroglobulin is a broad spectrum. Now, just one slide about alpha-2 macroglobulin. It is a broad spectrum protease inhibitor. Proteases are responsible for breakdown of cartilage. When normally alpha-2 macroglobulin normal value is 1500 to 1800 per microgram per ml. This concentration in the synovial fluid is not that high to inactivate elevated levels of catabolic agents, which is a common feature of osteoarthritis, right? So if we can take alpha-2 macroglobulin, we have commercially, the last picture shows on the bottom, the commercially available kits, we can separate it from the plasma. But if you use leukocyte, that costs a lot in different parts of the world. But if you use this leukocyte poor PRP, you will have almost the same effect along with the effects of PRP. This is some evidence, courtesy Richard Rosenthal, that we have level 1, level 2 evidence for ONE, same for trochanteric bursitis, rotator cuff, lateral epicondylitis, patellar tendon, plantar fasciitis. And we all know that the most difficult tissue in the body to regenerate or heal is the disc. And there is level 2 evidence. And I would say most of the research dies in the disc. We don't get positive studies. But now we are also planning a study, and we are ready to collaborate to use the combination of platelet leukocyte poor PRP along with exosomes and autologous stem cell therapy intradiscal, and then we'll see how the things come up. Right, this is one again the evidence. There was a study done that whole blood was taken and it was converted into leukocyte-rich PRP, leukocyte-poor PRP, packed RBCs, and PPP. All these were injected into articular or were exposed to the cartilage, and the outcome showed that RBC-free leukocyte-poor PRP should be used for intra-articular injections. So again, this is good evidence published by Elrie J. Braun and others. So this is a good paper, good study published in 2014. Right. This is one of our recent papers accepted for presentation in World Clinical Neurology to be held October this 2023, and where we proved that injection of PRP on different acupuncture points for intractable with patient who had intractable diabetic polyneuropathic pain, and we compared with the pregabalin. So results were excellent and with 1 year follow-up. So we'll be sharing one. We have presented this paper. Another study, 16 patients with degenerative disc disease, and 9 of them had degenerative disc disease, and the others had 9 with also disc arthrosis, calcification, and foraminal stenosis. So 3 injections at 3-month interval, follow-up at 3 months, 6 months, 1 year, 2 year, leukocyte-rich PRP, 1 cc intradiscally, 3 to 4 cc paradiscally, and with good outcomes. Right. So result patient satisfaction was 90% and 24 months, pain relief at 2 to 4 point decreased, even 2 years. So although there was no improvement in height or change in hyperintensity or MRI image, no modic improvement. So this again is that degenerative disc disease or degenerative disc pain is more of inflammatory based process rather than the physical process. Right. Another study, PRP for facet joint injection, 60 to 70% pain relief, improved range of motion, and reduced medication. So, so we have some. This is Another paper of ours, not for pain, but a young patient with gangrene of the left toe. I will be sharing the pictures. This is how the patient presented to us. You can see he had fracture, he came from some village, it was fixed, putting a needle, got infected, and you can see how black and dark it is. We sloughed off all the things, injected PRP locally, and then we did photobiomodulation low level, and you can see this young guy's finger was saved, not only, and also the nail started regrowing. Right, so reasonably good level 1, level 2 evidence of PRP for both pain, degenerative condition, and other conditions as well. Now, stem cells, two basic characteristics. They can self-renew to produce identical daughters, and they can all, that is called the typical cell division. They can also go through atypical cell division, where they produce a lipid or a fat which combines with the free cell and produce the progenitor and the specialized, and also so typical where they produce identical stem cells, and atypical, asymmetrical, where they have one specialized cell and one stem cell. Types according to differentiation potential, origin, totipotent, pluripotent, multipotent, all those things will not take much time. Then embryonic stem cells, umbilical cord derived adult stem cells. We will be talking about adult or autologous stem cells. So we have already discussed bone marrow derived concentrate, then adipose derived stromal vascular fraction, peripheral blood derived very small embryonic like cells. 4 very important properties: self-renewal and potency, specific lineage, multi-drug resistance, plasticity, and differentiation, right? So now coming to the contents of the Buffy code or the BMC contents. BMC means bone marrow concentrate or bone marrow derived concentrate. So it has maximum number of hematopoietic stem cells, that is 1 per 10 to 15,000 marrow cells. Right, then mesenchymal stem cells is 1 to 250,000 marrow cells. It has both precursor T and B cells, white blood cells, concentrated platelets with all the growth factors. It has scaffolding proteins, fibrinogen, fibronectin, alpha-2 macroglobulin, anti-inflammatory cytokines and interleukins, IL-1 beta, IL-6, IL-8, bone morphogenic proteins 2 and 7. So you can see it's such a beautiful, strong cocktail, and we can use it for all types of healing process. And what hematopoietic stem cells do, they give rise to other blood cell types such as RBCs, WBCs, platelets, growthlets, endothelial cells. So and the other things is they also are important with other executives, that's intercellular communication and all those aspects. Then we have mesenchymal MSCs. It can differentiate into fibroblasts, osteoblasts, osteocytes, adipocytes, chondrocytes. So all MSK conditions can be treated with these. Also, hematopoietic stem cells, and they upregulate cytokine release, stimulate stem cells to promote regeneration. And use of BMAC is considered, again, there is no enzymatic, nothing, just the centrifugation, and you concentrate the thing and then you can re-inject it. And it can be done all over USA. FDA has no problems with it. Then BMAC contains a mixed cell population, which is believed to enhance the performance or the efficacies of mesenchymal stem cells, especially in MSK conditions. Now coming to adipose-derived stem cells. So what we take, we or the plastic surgeon takes the peri-abdominal fat, or it can be taken from hip or thigh, 100 to 150 ml or even 50 ml. In children, 20 to 30 ml, depending upon what age and this quantity we get available. It's simple. It's lipoaspiration, not liposuction, lipoaspiration under local anesthesia. Once it is done, then we treat it with collagenase 1.1% and normal cell line, incubate it for some time. Then washing is done, centrifugation is done multiple times. We treat it with antibiotics. It's not a difficult procedure, but you need to have a sterile biosafety level 2 facility to process all these things. And the final product is called the stromal vascular fraction. Stromal vascular fraction is a cocktail of different stem cells, including the maximum number of mesenchymal stem cells, then 5 to 7% of hematopoietic stem cells. Then we have different progenitors, we have adipocytes, we have epidermal, all those. So it's a beautiful cocktail again. And as this has much more number of mesenchymal stem cells, so this is can be much more suited to the MSK condition like intra-articular injection or all those things. Right, so this is the composition, both MSCs and HSCs, then endothelial cells, pericytes, fibroblasts, macrophages, B and T cells, precursors of B and T cells, extracellular matrix molecules, growth factors, cytokines, all those things, right? So again, a powerful stuff if we do to start regeneration. Now coming to the third, that is the very small embryonic-like stem cell. This represents a very small population of extremely small non-hematopoietic pluripotent cells, which express as CA1 in mice and CD133 in humans. That is the marker for non-hematopoietic cells. These are released is in the circle when somebody gets MI or any on heart something, they are released from the marrow and they migrate and help in repair of those things, right? So the proposed mechanism for formation of them, normally primordial germ cell, they are responsible for oocytes, oogonia, both sperms and gametes and oogonia, all those things. Then through they form very small embryonic-like stem cells, and through an imaginary hemangioblast, that is an intermediary condition, it forms both hematopoietic stem cells and endothelial progenitor cells. They can also form mesenchymal stem cells and tissue-specific stem cells. So the difference between the bone marrow-derived, this adipose-derived SVF, and peripheral-derived VSCL is that it has all the tissue markers or the surface markers positive, which are positive for pluripotent cells. So it is theoretically, it is more strong, it has potency to more regenerative cascade. Right? So how this procedure is done, normally the bone marrow concentration mononuclear cells is very low, it's 0.06%. If we try to harvest, we can't harvest. So for that, what we do, we inject filgrastim 1 ml 4 consecutive days, because it increases the number from 0.06 to around 26 to 30 on 4th to 5th day. And then the next, after 4 days, we call the patient on 5th day, ask him to take lots of fluids, secure an IV line, 16 gauge cannula is passed, and then this is the system we use. This is Haemonetics multi-component system, and this is the kit we use. It contains multiple bags, one for buffy coat, one for platelet poor plasma, and then on the right side, this is where we get the mononuclear cells. The product normally we process about 2.5 to 3.5 liter in 2 to 3 hours. This is a minimally invasive, just IV line, nothing else. This is how this procedure is done. Then we attach ACDA anticoagulant, so it should not coagulate. Then we have, this is where in the white cell layer we find the mononuclear cell, Latham bowl centrifuges and separate the different layers. Right. So again, this is one of our very recent papers, again accepted for World Congress of Neurology. This is where we treated Parkinson's disease, which were not responding to patients with peripheral biliary drive. Again, can't share the data right now, but we'll be sharing once this is presented and published. I mean, this is the first of its type, the study we have performed, and with beautiful outcomes. We'll love to share this in October after the conference, inshallah. Then again, already published data that it can help regenerate the bone tissue. Right, again, different studies for degenerative disc disease using autologous mesenchymal stem cell derived from bone marrow. Then 1 year follow-up, 3 months, it was 85% improvement, both in pain and disability. 1 year, it was 71%. Significant improvement in water content, no increase in height. But again, the point is that discogenic pain is more of inflammatory pain rather than a physical pain, right? Another study with systematic review, but again, the problem was the methodology was poor. It's the time where we need to have good quality studies, so evidence should improve, right? Another study with 3-year follow-up, excellent outcomes, right? And 3-year follow-up is huge. Another prospective trial by Sriram, 2021, taken a BMC with 40, then conventional 40, follow-up 1 year with excellent outcome. You can see also the disability index score, NRS score, numerical rating scale, your EuroQOL, global mental health, so all improvements. So, but again, the point is it's pro-inflammatory as because they have immune modulatory effect and anti-inflammatory effect. That is where all the improvement comes. Again, another paper of ours for diabetes mellitus using peripheral blood drives, good outcomes. So just a brief introduction. I'm going over time, but we'll take 2 to 3 minutes more. So exosomes are basically small nanoparticles which are secreted by cells in response to stress or dose. Their normal size is 30 to 100 or sometimes 30 to 150 microns. Right, this is how they produced invagination of the cell membrane, early endosome, then late endosome, then they combine to form multivesicular bodies, and ultimately they are released. They are important intercellular communication. They contain RNA, mRNA, so all different things which are good. And the best thing is when we add exosomes along with PRP or with hematopoietics, mesenchymal stem cells, it improves the hostile environment, and it also improves the quality and the stimulatory effect and also the regenerative effect of the cellular treatments we are using. Right, what it does, it improves the hostile environment, it hampers, right? It promotes mesenchymal survival and function by improving the decreasing oxygen tension, decreasing the quality and the count of metalloproteases, all these things. So exosome may be the primary driver of mesenchymal stem cell driven regeneration and could represent a potential alternate treatment for degenerative disc disease. And this is what we are basing, and we are planning a comprehensive randomized study over a period of next, we'll enroll patients. We are already started enrolling patients. We'll perform one session at minimum 1 to 3 levels of the disc, and the exclusion criteria is non-calcified disc, and where the height is not less than 50% of the normal height. Let's see how the results come up. So coming to evolving application, we can see osteoarthritis, degenerative disc disease, autoimmune diseases, rheumatoid arthritis, ophthalmological conditions, sports injuries, damaged tissue, organ regeneration, like liver, kidney, pancreas, skin, bladder, all those things, vascular, both intracardiac, peripheral. Beautiful work done in Europe for intracardiac injection in acute MI cases with beautiful outcomes, peripheral nerve, spinal cord injuries, burns, craniofacial. So this is the beauty of regenerative medicine, that we can address not only the pain conditions, also any neurodegenerative, neurodevelopmental condition. So huge potential. I will be sharing some pictures. This is, you can see fracture of C7. It presented to us 9 months after the injury, non-healing injury, right? And then we did peripheral derived stem cell. You can see on the left, pre-treatment. This is post-treatment healing. So you can see we did local and then we did an IV infusion of the same PBD. So excellent outcomes. Then another patient of mine, you can see how much big this disc is at LL4, L5. So for this, we had that patient had impeding caudate vena, but they were absolutely not willing to undergo surgery. So what we did plasma ablation nucleoplasty procedure to reduce the volume of the disc, and then for 4 weeks following the plasma ablation nucleoplasty, we injected intradiscal peripheral blood-derived stem cell along with PRP, both in L4 and L5 disc. You can compare both the discs that though the disc height is not increasing, but you can see the difference. There is increased water content or increased height on the right picture. So this is another patient of ours, degenerative advanced knee arthritis. And this is pre-procedure on the right. You can see lots of inflammatory fluid on inflammatory, and there is absolutely no height of the cartilage. On the right side, you can see normal fluid, and you can see the thickened cartilage. Again, nice outcomes. Then this is a beautiful, good example. Our patient, rheumatoid arthritis, young dentist, fresh graduate, a huge lancinating pain, 8 to 9 by 10. What we did 3 sessions of intraarticular PRP along with high molecular weight hyaluronic acid, and then we did 1 session of peripheral blood-derived intraarticular. This is when we do intraarticular under fluoro. Then you can see there is development of the joint space. And this is, now you can see the whole outline. If you compare it with the wet line, that whole, not only the region, it has whole, we can see this, right? So this is another example of osteoarthritis of hip, quite advanced. And here you can see same patient, there is more joint space with cartilage and all those things, right? And now we also have changed our protocol. First, we were doing only intraarticular. Now we are also injecting intraosseous, because intraosseous is where all the regeneration comes from. So we go intraosseous using this orthopedic needle and inject PRP and stem cell both. And we will be publishing this data as well by the end of August, of 30 patients doing both for knee and hip, 20 knee joints and 10 hip joints. And so far the results are excellent. This is our work for retinitis pigmentosa. Usually patient lose their sight, nothing to offer. Here you can see from 6 by 6 to your finger counting to 6 by 18. So lots of benefit. And here you can see this very few, and here on the right side after the treatment, lots of improvement in visual field in retinitis pigmentosa patient. Then there is, you can see the thickness in the center, 104. It has improved to 1202 in Stargardt patient, again a chronic degenerative eye disease. Our work with CPs, flaccid CP, started holding things. Now this child is now, alhamdulillah, 20-year-old, and we treated him nearly 19 years back. He's going to college, getting a degree, doing a normal life. Another spastic CP treated with PRP and photobiomodulation, weakness of the left side, same child putting and running, so all the weakness gone. So this is corticovisual and epilepsy in a young child, we treated with this adipose-derived stem cells, PRP, photobiomodulation, vision restored, epilepsy gone. We can also use it for hair regrowth. So different outcomes. So the way forward, the future for regenerative is bright. I would say the future of medicine, as Professor Amar in his introduction said, that the future of medicine is regenerative. It's still young. Much more research is needed. We need people. We need collaborative effort. We are ready to share our protocols, what we have done, and we are ready to learn from others. So we need to combine, and we need to, so 3D printing for matrix, engineering, all those things, precision medicine, the use of personalized treatments based on I mean, this is the whole future. 3D printing, precision medicine, bioinformatics. So this is, it's not a blob or so. So what we need to do is we need to learn from others, need to learn from our experiences, our own mistakes, integrate all possible modalities with good and promising evidence for the treatment of different diseases. Because as a Muslim, we firmly believe there is no disease for which Allah Almighty has not provided us the cure. We simply have to try our best, and we must discover this. This is my email. If you have any questions, queries, you can write it. You are right. Thank you so very much. Thank you.
Perfect. Perfect. As usual, Professor Shahzad. It's amazing to have these results and to have the clinical correlation between research and clinical outcome. It's amazing outcome that we would like to have for all our patients. I have a quick question here coming, saying that how do you convince your patients to wait for like 12 months or 6 to 12 months to have a result, where people usually they are in a hurry to have have a good result?
Right. So what we are doing, we are combining state-of-the-art interventional pain management techniques and following it with regenerative medicine. Right. So if, like I showed the MRI of a patient of mine who had impeding cauda equina, right? So what we did, and she had a pain score of 9+ at that time, screaming, could not lie down, could not sit. So what we did to treat her pain, we did plasma coablation nucleoplasty, beautiful evidence procedure. FDA approved it in year 2000. So that does volumetric reduction. Along with, when we come out of the disc, we perform transforaminal epidural steroid injection that takes care of the pain, right? But similarly, if patient comes to you with severe pain, right? He is not concerned about, he or she is not concerned about the degeneration or whatever is going on. Treat the pain, and once that you treat the pain, patient is comfortable, not only the patient, whole the family, and they will trust you. Now you tell them that if we have done this radio frequency genicular neurotomies or medial branch rhizotomies or anything, you have done this, or even neuromodulation, whatever if there is a mixed or sensitive enough, right? You tell them that this is a short-lived procedure. Patient may come, pain may come back a month, 6 months to 1 year. But once you follow this by regenerative cascade, right, you treat the patient's severe knee pain by peripheral blocks of genicular nerves, infrapatellar branch of the saphenous nerve, do the RF rhizotomies, and then you ask the patient to come after a fortnight or 4 weeks to then you do the regenerative cascade. And then again, there is one misconception, that it's not always it takes 1 year to improve the symptoms. No, we do intra-articular PRP along with Synvisc, that is high molecular weight hyaluronic acid, and then we inject tramadol, that is preservative-free tramadol. There is lots of evidence published that intra-articular tramadol helps in chronic knee pain. So when we inject along with PRP tramadol to the product we have is 2 ml with 100 mg of tramadol. So what we do, we mix that along with the PRP. So 3 ml of PRP, that is leukocyte poor PRP. And we only realized this a couple of years back. Before that, we were using, like every other body, leukocyte rich or Waficot. But now intra-articular, we are only using leukocyte poor. We don't get flare-ups, and we see lot more improvement in symptoms and also long-lasting. So there are two types of effects of stem cell therapy if we talk of. One is indirect effect. That is the stimulation of already weak cells, right? So they start functioning better. So regeneration starts indirectly. Meanwhile, what happens that the cells we have injected by the process called homing, they reach the disease or inflammatory tissue and home there, right? So there have been different studies published by Germany. They radioisotope the stem cells, injected it, and then they migrated to the diseased tissue. If they treated some patient with this cerebellar atrophy, they give IV, or even certain patients were given intra-articular. But when they did PET scans after this, or they did radioisotope, then they found that more than 90% or 99% were there in this cerebellum. So they migrate there, they home there. So because all those degenerative tissues and inflamed tissues are giving SOS signals in the form of cytokines and chemokines. So that is the major attraction for the mononuclear or stem cells to move there. So indirect effect comes and patient feels better within first few weeks. Then the actual regeneration, if we talk of, that takes around 6 months to 1 year. That is the window where the maximum benefit, and it can last for years to come. So this is not true that when we inject, we give PRP or stem cell, it does not take 1 full year, right? If pain is mild to moderate and the patient's more concern is degeneration, then we can straight away go for the regenerative modalities. But if the patient is coming to us for the acute pain, severe pain, acute or chronic pain, first treat the pain with intervention or whatever modality we know, then go for regeneration.
Clear, very clear. One simple question came, Dr. Said, how do you separate the leukocyte poor from leukocyte rich?
Yes, I already mentioned, I will mention it again. Once we have done the centrifugation, we'll take out the Falcon tube or the PRP kit we are using. We'll let it rest for 5 minutes. Then the differentiation point between the RBCs, where we find the buffy coat, that grayish material, right? Just half centimeter or 5 millimeter above that point, just mark the line. And when you take your sample, your needle should not go below that point. So you will aspirate 1 ml, 2 ml, or whatever the quantity you want. That is the area where you will have good number of platelets, very few number of leukocytes, and the maximum concentration of alpha-2 macroglobulin.
Very good, perfect, great. Look at, there's a question regarding autistic patients. Do you have an experience for that?
Yes. I mean, so far in last 20 years, we have worked with more than 500 autistic kids. Actually, we are working with different autistic centers here in Lahore and also one center in Sydney. We had 27 patients referred from Sydney to us. And our protocol was, they came to, if they are local patients, we perform 1 PRP session. That is, we take 20 to 30 ml from the kids, not more than that, prepare the PRP. And then we do 2 things. We mix that PRP after photoactivation or all those things in 100 ml saline and give IV. The remaining PRP we give on 3 or 4 acupuncture points. Right, we all know that acupuncture influences circulation in brain, oxygen perfusion, glucose metabolism. There have been PET studies, functional MRIs done, different acupuncture points stimulated different areas of point. So the points regulated with prefrontal cortex circulation is stomach 36 and large intestine for some acupuncture point. And we also inject 0.3 to 0.4 ml of PRP at these acupuncture points along with IV infusion in 100 ml of saline. So 3 injections, 3 sessions, 4 weeks apart. And then we follow this with adipose-derived stromal vascular fraction. Again, the protocol is same. And the one part is given IV infusion and the other part 2 to 3 ml we give on different acupuncture points. So if somebody can share the email, I can share the outcomes of my study recently published and also our previous studies. So beautiful outcomes in autism.
Perfect. We'll communicate with the concerned person. That's great. So thank you very much. It's great. So any questions you need to ask, the email of Dr. Shahzad was there. So I'm gonna show it to you again later. And then we would like to thank Dr. Shahzad for being with us. As mentioned at the beginning, this series of pain and regenerative medicine is up to date on what's going on for our pain community and for our pain patients. So this is the first lecture. I wanted it to be very clear, updated. I was confident that we will have great talk. The next talk will be a presentation from me regarding the ultrasound, how the ultrasound can help our patients in a daily basis. We know that the new generation is fun for technology and new technology. Now with all the artificial intelligence, also we have more and more questions regarding how ultrasound can go further, and I'm going to show some of the examples on that. So thank you very much, Dr. Shahzad. I'm going to start sharing my screen, and share my screen, and then perfect. So it's a pleasure for me to present a little bit of updates on what's going on regarding the advanced ultrasound for chronic pain. I'm glad to present my my hospital where I work currently in Abu Dhabi, Cleveland Clinic, Abu Dhabi. And on the left side is the place where I grew up. It's René Descartes University in Paris, where I learned a little bit of pain. As a disclosure, I'm founder of the Gulf Pain School, as mentioned at the beginning. And recently I was elected as president of the World Society for Pain Clinician, which makes me more into my laptop. So I'm having more time to spend on my laptop because of this new responsibility. The objective is quickly to have an overview on ultrasound technique for better scanning, look at the evidence for ultrasound in pain medicine, and illustrate areas of interest in ultrasound pain medicine. So, recently, I mean, like say 10 or 15 years from now, earlier, there has been a tremendous growth of interest in ultrasound pain medicine, increase in the literature, ultrasound guided pain procedures, which also necessitate a little bit of technical skills, where we can see more and more workshops ongoing all over the world. And the workshops not only on humans, even in sharks, we have the application of ultrasound, which can help with some diagnosis and interventions. Technical skills are needed for ultrasound in pain medicine, specifically because we have some challenges that I'm gonna share. And the advantages of these techniques is to have a direct and dynamic visualization, real-time needle advancement. We can see all the vulnerable neighbor structures like vessels and different anatomy, differences in anatomy, less risk of radiation and X-ray hazards. This is very obvious. It can be office-based procedure done under ultrasound, and the machine itself is very affordable compared to other modalities. One of the major problems with the procedure relying on landmarks when we used to do that is the high failure rate. So high failure rate is something we used to face when we have landmark technique or blind techniques. As I said, limitations are there and challenging are important to mention. First, operator dependent. It requires experience where we need to have real coordination between needle and the target. The quality of the image in certain areas can be poor, like in spine, for example. I'm going to show some of the examples where you have a high attenuation coefficient for deep structures. Deep structures is also optimal because of low frequency probes have lower resolution, and the visualization of the thin needle or needles inserted in a steep angle with the development of echogenic needles. This limitation may be overcome, but still we have some challenges to face when structures are deep. Some of these advantages may be seen as advantages, where ultrasound opens excellent possibility to teach and learn about anatomy, variation in anatomy in different patients, and we can do this during our training for intervention pain therapy. So handling is essential for ultrasound, and we know that we need to be very accurate, and we need to spend time, and we need to follow some recommendations to get to the right image and the right target. When you look at this series of interventions that can be done under ultrasound for spinal and non-spinal procedures, we have evidence which are rising, and we know that we're starting to have evidence 1 to evidence 4, which is going from conclusive as level 1 or intermediate as level 4. But overall, all these modalities, spinal and non-spinal procedures, can be done under ultrasound with certain evidence in the literature. The first one, which has been the first to be introduced as a good advantage and moving from the landmark technique or the fluoroscopy technique, is the stellate ganglion block. We know that the fusion of the inferior cervical and the first thoracic ganglion is the stellate ganglion. It is lateral to the longest colli muscle, which can be seen easily in ultrasound, and posterior to the vertebral artery. So one of the advantages is that we can activate the color Doppler, and we can have a good visualization of the vertebral artery, especially when you are at the level of C7. Don't take the risk of injecting and doing the stellate ganglion at the level of C7. C6 is the safer, and you can have a good spread of your injectate, even you're performing at the level of C6. This is where we need to go. We need to cross this red line here, which is the prevertebral fascia, which is very easily seen as hyperechoic line when we scan at the level of the C6 here. And by scanning, we know that if you move from the transverse process of C7, we see the vertebral artery, the longest colli is above. And if you move one level up, we can reach the C6 level, and we can have a good visualization of the prevertebral fascia and inject below the prevertebral fascia. So we need to have a real spread of local anesthesia of the injectate down to the longer colli muscle, down to the prevertebral fascia. So very obvious and important measure to have under ultrasound with very good outcome. When we go for cervical nerve roots, for example, when you would like to be very selective, it's easy to be around the nerve root. We know there are some elements important to see when you are at the level of C6, for example, when you see the U-shape tubercle, anterior and posterior tubercle at the level of C6, as you can see it here, where the nerve root is exiting the spinal canal. And these are the images that you can see on the left side, where you have anterior tubercle, posterior tubercle, and you know that the nerve root at this level is the nerve root of C6 level. And if you don't have anterior tubercle, you have only posterior tubercle, you know that this is the C7 level. When you have the shape of posterior and anterior tubercle blunted, like very minimal, you know that you are a little bit high at the level of C5, and by moving up and down, by tilting a little bit the probe, you can get to the right level you would like to inject. Again, this is the C6 level where you have the anterior and posterior tubercle very prominent. Again, activating the color Doppler is something important because there are some cases where you have at the level of C6 even 10% of the vertebral artery can be visualized and can be seen. So activating the color Doppler is always important when you start scanning and injecting. The other structure that is important for ultrasound guided blocks and procedures is the suprascapular nerve. We know that it comes from C5-6 level and travels along the suprascapular artery, and we can have very good visualization with ultrasound reaching and having the spine of the scapula as a landmark. We do first palpation with sonopalpation, we call it, with a probe, and then we go above the spine, having the levels of the two levels of the muscles, trapezius muscle and supraspinatus muscles, and then we can visualize the suprascapular notch where you have the artery and the nerves running through this notch. If you go and tilt and do good scanning and good fine-tuning of your image, you can even see a hyperechoic line, which is represented by the transverse scapular ligament. Again, here we need to activate the color Doppler to have a good visualization of the artery. In this case here, where you can have a good guide for your suprascapular nerve block. Another indication for a good visualization and good outcome for injections after ultrasound guided block is meralgia paresthetica, where you have the lateral cutaneous nerve of the thigh is visualized, and the one particularity of this nerve is that it has a lot of variability. So you cannot rely on landmark techniques or on stimulation or whatever to get a good result. So with ultrasound, you can really scan and you can follow all the bifurcations and the variations of the lateral cutaneous nerve of the thigh by the ultrasound. And you can see it with scanning left and right. One of the landmark is the muscle, sartorius muscle, where you can go and see and look at the lateral side, seeing that, feeling the fat pad where the lateral cutaneous nerve of the thigh is lying. When it's compressed by the ligament, inguinal ligament, you can see and inject in this fat pad, and by this you can visualize, you can even create a sort of contrast which will help you to have a good visualization of your lateral cutaneous nerve of the thigh. And again, for scanning, we start with scanning the normal structures or the more obvious structures on the inguinal area, where you can see the vertebral artery, the femoral artery, the femoral vein, and scanning more laterally, where you can see all the muscles and structures, leading to a good visualization of the lateral cutaneous nerve of the thigh. In this case here, moving from the femoral area where you can inject on the femoral and move laterally to have good visualization. All the muscles can be seen. The important and very obvious advantage of ultrasound is the era of musculoskeletal scanning. We follow these tips for a good scanning for MSK, ultrasound guided interventions for musculoskeletal blocks. It's represented here by this acronym LUF. Landmarks. We stay with the bony structures and we try to have a vision on 3D imagination. The axis can be long or short, with better reflection when you have a short axis. Ultrasound probe handling is important, and always think about your coordination and how you can keep some room for injection. Get the feedback from the patient. This is an important point where you have a good outcome and you have good response and feedback that can help you and guide you where to place your tip of the needle. And hyperechoic or hypoechoic spots for muscle lesions can be correlated directly to the pain. This morning I was doing a case where I was having a small hyperechoic structure within a muscle, and when I reached this area, the patient herself started saying, yes, this is a point where I have pain. So we can be guided by our patients in these cases. The other indication for MSK is the piriformis muscle injection. We know that the key landmark is sciatic notch. Below the piriformis muscle, we have inferior gluteal artery, sciatic nerve, pudendal artery and nerve, and all these structures are important, and we need to avoid lesioning them and avoid them carefully by using very accurate regime like ultrasound. So fluoroscopy guided piriformis rely on sciatic notch and SIG, but you have accuracy of 30%. So I don't think there's any room for piriformis injection under fluoroscopy. Ultrasound is the key for that. And we know that by scanning and moving from up to down from the gluteus area, we can see how we can get to the sciatic notch. And from there, we know that two layers of muscles are easy to identify, gluteus maximus and the piriformis muscle. And by tilting a little bit, we can have this sliding and asking the patient to move the leg, sliding of the piriformis muscle, as this picture here, where the piriformis below, we can see here the three structures, the gluteus maximus, the sliding of the piriformis, and the sciatic nerve below the piriformis. And then from there, we can avoid any injection and any injury of the sciatic when we target the piriformis muscle. The other area is the quadratus lumborum block, where we have lots of indication from this, and we know that spread of the injectate either from each of these types of quadratus lumborum, the lateral, the posterior, the anterior. We changed now from the QL1, 2, and 3. So the injectate and when you look at the 3D studies, we know that there are a lot of spreading up to the thoracic area, and the indications are spreading a lot in chronic pain mainly. Of course, we know the advantage on the regional anesthesia and the acute pain, but in chronic pain, we're having more and more indications for these QLB. So Dr. Shahzad was talking about the osteoarthritic hips, for example, where they need to have something strong for analgesia when they do their regenerative medicine procedures. QLB can be one of those that helps for hip pain. Again, we change now from the QL1, where you have the tip of the needle above and that below at the QL2, and then you have the QL3 transmuscular. We changed now from these nomenclature had changed from anterior, lateral, and posterior. Rectospiny blocked, plane blocks. It's a facial plane block where indications are spreading. We have more and more indications for that. We know that we with ultrasound we can be very accurate in reaching the plane where we need to inject. These illustrations of reverse anatomy from Nysora group showing how we can reach the superior edge of the transfer process at this level here. by moving from from cephalad to caudad in this case here, and sliding from lateral, where you can see the ribs, towards the medial side. You can reach these layers of muscles where the transverse process is visualized in this case here, and the needle can be reaching exactly where we need to peel and inject, and have the injectate spreading longitudinally along the transverse processes. Hip injections are also important. Tazad was talking about hip injections, which can be done very easily to prepare patients for regenerative medicine, for something more in chronic pain. When it goes to chronic pain, we need to know that many options for the hip injections. We can use steroids, we can use hyaluronic acid, we can use growth factors, PRP, stem cells, and the accuracy of our tip of the needle is paramount. We need to know that we have vascular structures in there. You can see the femoral artery in here. So we are deeper than that. So we can be more accurate with the needle in plane technique in here, reaching the inferior-medial acetabulum and at this level here, where the local anesthesia is injected, or the injectate is placed on that tip of the needle. So many advantages on having a direct visualization, avoiding complications. We have also to think about the pink block also, which can be one of the indications with ultrasound. It can help also for acute and chronic. Here we can see the tendon of the iliopsoas tendon visualized here as hyperechoic structure, and by avoiding it and reaching the iliopubic eminence, we can have very good spread of our injectate at this level here, helping getting good pain relief from around all these articular branches. So it's more into articular branches. And talking about articular branches, when we do radiofrequency denervation, we need to think about combining fluoroscopy and ultrasound. And ultrasound will be the guidance for avoidance, to avoid all these vascular injuries when we do under fluoroscopy. So something that needs to be considered doing the combined techniques, fluoroscopy and ultrasound. And this is the image, these images where you can see the pericapsular nerve group pink block, which can be this with the probe placed oblique at the acetabulum area. If you want to be iliopsoas plain block, you need to tilt and have more vertical probe, and then the needle can be in plane technique, can come from below for in plane technique. And of course, the anterior hip capsule is also one of the targets and can be visualized easily with ultrasound. Knee injections, to finish with all these blocks for MSK. We know that the knee is very well innervated, and there are lots of variations of the innervations. We know that lots of genicular nerves coming from different parts, different nerves, an obturator, the femoral, sciatic for the posterior area. And we need to always think ultrasound to have good spread of your injectate when you inject. For example, for geniculars, when you do the superior-medial genicular nerve, in this case here, we know that the artery is accompanying the nerve, and by activating the color Doppler, we can be very efficacious, and the spread of local anesthesia can be visualized, and we have good spread of local anesthesia under ultrasound guidance. The inferior-medial, again, we can have it as a short axis or long axis, and activating the color Doppler is something important. And the injectate can be around the vessels, reaching all these network of nerves at the inferior-medial genicular artery. The inferior-lateral is always avoided. We avoid it because of the risk of drop foot. Some specific probably specific pain at that level, inferolateral, can be sometimes we can use some of short-acting local anesthetic in order to have a diagnostic test with very good monitoring of the patient to have a very specific diagnosis for the inferolateral, but mainly for denervation, the inferomedial is our target. Again here with the short axis view where the tibia is there, is seen at this level, and the injectate will spread around the funicular nerves. Again here, vessels are seen easily, and then one nerve that sometimes is important to block for knee pain, especially for post-surgical chronic pain, is the inferopatellar branch of the saphenous nerve, and this can be visualized as you can see here at the medial side, coming and turning the probe to have the nerve as a short axis, and you can see it in this case here, and block it, do the diagnostic test, and then if needed to do some radiofrequency ablation. Can be also cryotherapy, it can be cooled RF, any technique that can give you a large lesion is welcome for this great area where you have lots of network of nerves at this level here. The spine, to finish with all the indications, is something challenging. We need to really master the approach and how to tilt the probe to have the good visualization of the structure that you would like to block and to inject. We have the basics that is taught to our colleagues when we do our courses. Spinous process, the lamina is the first line, hyperechoic line from each side, then your transverse process. If you walk off the spinous process, then you have the anterior complex with the vertebral body and posterior longitudinal ligament, which can be seen, and the spinal canal, which can be seen. When we teach these on models, on water bath models, which can give similar images. So don't expect to have this image in all your patients, but when you learn about it, it's good to have the perfect image. When the target is deep or sheltered with bone, real-time navigation is not possible. So sometimes we need to have technology to help us, and this technology can help with this kind of fusions, for example, where the images can even be almost equal to the MRI scanning, where you can see the images exactly like you see it on MRI. So this technology can be also of great help sometimes with this fusion techniques. All the blocks that can be done in the spine can be done by ultrasound. We know that we moved from this gross anatomy to the stenoanatomy, where you can see all the structures in the ultrasound images, moving from medial to lateral, from the spinous process to the lamina to the transverse process. And we know that the probe should be moved from transverse to longitudinal to help getting the as if you're doing AP and lateral on fluoroscopy. So it's just if you want to be accurate, you need to have always two views with your ultrasound probe to get to your image out of plane or in plane according to your scanning. And this is how we can approach, for example, the medial branches between the superior articular process and the transverse process. And the image is seen as in-plane technique here with the needle visualized. By small tilting, we can see also the gap between the superior articular process and inferior articular process, which is the facet of that level. So lots of elements can be done and seen with ultrasound guidance. Then for the cervical area, we can have good visualization with a large footprint, which can show different levels. This is what we call the Korean technique, where with one entry point, you can block one or two facets at different levels and do the diagnosis. And then if you decide for radiofrequency ablation, then the fluoroscopy is something we need to have and to use. This is important point. We don't rely on ultrasound on everything. For safety, we need to have the fluoroscopy for those blocks or denervations that are at risk. We can combine, but you need to be clear that not everything is done on ultrasound. We need to find that. So third occipital nerve, which can be seen in this here very clearly, where you see it's needle branch of the C2, C3, so very easily to be seen and to be blocked when you have a cervicogenic pain, cervicogenic headache. Third occipital nerve can be one of those targeted by ultrasound, and it's very easy to perform. The sacroiliac joint, we know that with fluoroscopy sometimes we struggle with it. With ultrasound is something we learn to have easy and quick, where you can see the junction between the sacroiliac, the sacrum, and the ilium, and then the joint is visualized easily, where the needle can be hooked at the level of S2, the best area where you can see it, S2, where the joint is large and you can inject very easily with that. So something that we can use also to have a good visualization is to activate the color Doppler when you start injecting. When you start injecting, you need to see first to be sure that the tip of the needle is there and the injectate is going in the right direction. So this can be helpful with the color Doppler activated. So to finish with, after this overview of blocks and areas that ultrasound can be helpful, we know that practice is essential. Handling is very important. We need to be knowledgeable about anatomy. We need to move from the gross anatomy that we learned all in the medical school to the new anatomy, the sono anatomy. This is an important point. Reducing the radiation exposure is an important advantage. Reducing the complication, and we're having more and more evidence for that with high grade of evidence. And will be more important in the future with what we call intense focused ultrasound and fusion technology, which really getting into the artificial intelligence that can help technology to evolve and to go further and higher in the resolution and in the precision. This is the most important point that we had when we moved from the landmark technique to the fluoroscopy technique to the ultrasound. So accuracy and precision is the way to go. I think this with this I'll finish with this nice picture from Zayed Mosque in Abu Dhabi, and I thank you for your attention. And this is my email if you would like to have any questions, any lectures, I can hand over my lecture if needed for those who are requesting it. Thank you very much. So I can see that we have some questions here. Still some questions for Dr. Shazad regarding stem cell in diabetic neuropathy. Dr. Shazad, if you're still with us, they ask about neuropathy. Diabetic neuropathy, is there any role for?
Yes, definitely. If we talk of neuropathic pain, this is the damage to the peripheral nerves. And when we inject growth factors, whether it's PRP or followed by exosomes or stem cells in those areas, we can help regenerate. I will be publishing in next few weeks' time I also shared the study that injecting PRP on some acupuncture points and also the area where there is maximum pain, injecting PRP once a month for 3 months, that has helped them so much. The basic principle is I have a background of acupuncture training as well from Beijing University of TCM. So that we were, before getting into regenerative medicine, all those can find there are multiple studies published that acupuncture or laser acupuncture can help in reducing the intensity of diabetic polyneuropathic pain. Just taking on those principles, we take the leukocyte-rich PRP, right? Here we need to use the leukocyte-rich PRP because it's not intra-articular.
Yes,
we
sir.
are not worried about the chondrocytes and all those things. So here we take leukocyte-rich PRP, we can have RBCs, we can have Buffy coat, everything. And then we can mix them with methylated cobalamin, right? Which is again the building block of the Schwann membrane or the cell membrane, nerve cell membrane. So we, in the maximum, say if it's in the feet, where the maximum area is, just subcutaneously using the insulin needle 2931 gauge, you can inject 0.2 to 0.3 ml, or if you can find some acupuncture points, I can tell it the acupuncture points which are important. They are stomach 40, ST 40, you can find it on Google, stomach 41, gallbladder or GB 39, then stomach 36. So these 4 points are very important for the neuropathic pain of both the lower limbs, feet and legs, right? So injecting on these points, and then if you have any diabetic wound or all those things, you can also inject around those and also where the maximum pain is. This can help so much to your patients. And there is one other modality, we have been using it for years, that is the low-level laser therapy or the photobiomodulation. You can just, for skin conditions or neuropathic pain, we can use the red laser, which is 680, 660 nanometers. Even those 5 milliwatt pointers, which we use normally, you just can, again, you can use on these acupuncture points or the areas of maximum numbness, paresthesia, and pain. So you can apply that for 30 to 45 seconds. The mechanism of action for photobiomodulation is that what it does is that in the chronic injuries and chronic inflammation, mitochondrial dysfunction is there. That is because of in the mitochondria, ATP is not being formed. That is because there is the bond between cytochrome C oxidase and nitric oxide NO. So what these light photons or light molecules do is, when we bombard the laser light, that is a monochromatic light on those points, they dissociate the bond between nitric oxide and the cytochrome C oxidase. We need nitric oxide extracellular and where it is required to improve pH. And when the mitochondria gets rid of nitric oxide, it starts producing the ATP. So a regenerative cascade happens. So this is where the nerve regeneration happens. And there are lots of benefits, both for pain and people. We have 6 years follow-up of our patient where we did laser acupuncture or this PRP injection, not even stem cell. We don't put stem cell there, just PRP and photobiomodulation. And people don't come back for years.
Perfect. Last question from our friend Mudar from Abu Dhabi. NSAIDs and stem cells. Do you use them? When do you use them after injecting anything from stem cells?
Pardon, I did not get the question.
NSAIDs, non-steroidal anti-inflammatories. When you do PRP or stem cells, is not allowed. We know that we need to avoid for 5 days. Is this the case in your clinic, in your practice?
Yes. So it's still controversial as far as COX-2 are concerned. They cannot be given right immediately pre or post. But as far as COX-1 like etoricoxib, celecoxib, they are concerned, they can be used. There are now studies published by both Americans and European that they don't interfere with the cascade of, but still, if we want to avoid these, we can give acetaminophen, we can use tramadol, we can use orphanidine straight. So all these things, if we at all, but we can use the toricoxib or this COX-1 group, not the COX-2 one.
Perfect. Someone is asking, please, can you tell us the acupuncture points again? Which
Sure.
points?
Sure. This is for diabetic polyneuropathy. The key point is stomach 40, ST40. This is on the stomach channel. And if you write acupuncture points stomach 40, you will find so many images. Then stomach 41, 41, stomach 36. Then we have two other points from the gallbladder channel. That is GB39, right? And one more point that will also help improve the glycemic control, that is spleen 6, SP6. This is one point you give to any diabetic and measure the sugar level after 30 minutes, you'll find the drastic changes. So the other thing is avoid these patients giving these points in fasting patients, because acupuncture has a natural glucose lowering effect.
Perfect. That's great. So I wanted it short and sweet, but it took us more than 1 hour, 40 minutes. So it's great. The interest is great. I think we had, according to the company, more than 3,000 registrants, but live here I can see 505 participants, which is great. Thank you for your trust. Thank you for being with us. Expect more and more from this topic. It's a great topic for the future of our practice. And again, thank you very much and see you soon, Dr. Shahzad. Great to have you live. Thank you.
It's been an honor and pleasure. Thank you so much. Thank you so much, brother.
Take care.
Take care.
Take care, everyone. It's a topic for the future of our practice. And again, thank you very much and see you soon, Dr. Shahzad. Great to have you live. Thank you.
It's been an honor and pleasure. Thank you so much. Thank you so much, brother.
Take care.
Take care.
Take care, everyone. It's a topic for the future of our practice. And again, thank you very much and see you soon, Dr. Shahzad. Great to have you live. Thank you.
It's been an honor and pleasure. Thank you so much. Thank you so much, brother.
Take care.
Take care.